All right, y'all, welcome in. This is Professor Pence. Today I'm going to be talking about major depressive disorder. Here we have three different characters. We have Squidward, we have Eeyore, we have Sadness. I encourage you to utilize these characters or maybe a different character that comes to mind to be able to assess, does this character meet criteria for depression, major depressive disorder? Um, do they have other situations we need to look at? I mean, ask them more questions to actually figure this out. I encourage you to utilize this as a tool for learning so it sticks a little bit better. All right, now let's jump into it. This is going to be our learning objectives for this video. We're going to be going over the overview. What's included in the DSM 5TR chapter? What's even in there? We're going to go through some background information, some interesting stuff for what's happened with the DSM-5 versus TR versus DSM-4. We're going to go over the specific diagnostic criteria of major depressive disorder, as well as some information about examples, things like that. Differential diagnosis. What are some other considerations to have or to keep in the back of the mind when talking about depression? And how do we know the difference? Mental health assessments. What can you use? What can you use to support you? Mental health assessments itself, not to meet criteria, to be clear. So we'll talk about that. We're going to talk about some different cultural aspects and encourage you to continue to think about that as you move forward. What's the treatment and what are some examples of medication? So here we are. This is the DSM-5TR overview. Here's some examples of what's going to be included in that depression chapter. So please, flip open your book, look at that chapter, read along with me. We have the disruptive mood dysregulation disorder, major depressive disorder, which is what we're going to be going over today more in detail. Persistent depressive disorder, which is otherwise known as dysthymia, premenstrual dysphoric disorder, substance abuse, substance induced disorder, and then unspecified depression disorder. Also in the DSM-5TR is persistent grief disorder. This is going to be the background information about major depressive disorder and other disorders in the depression chapter. You can find this at the very beginning of that chapter in the DSM. So the DSM-4 used to have bipolar and related disorders in the same chapter, and now it's in separate chapters. The similarities are going to be presence of feeling sad, empty, irritable, whereas differences are going to be in the duration, timing, presumed etiology, as well as the presence of manic disorder, right, or manic episode. DMDD, disruptive mood dysregulation disorder, is utilized to prevent overdiagnosis bipolar disorder in children. Later in life, it's seen as unipolar depression or anxiety disorders rather than bipolar. DMDD is characterized by persistent irritability and frequent episodes of extreme behavioral dyscontrol up to 12 years old. So we want to be careful about not overdiagnosing folks when we don't fully meet the criteria and noticing that it changes over time as well. Yeah. Prolonged grief disorder in the DSM-5 TR, that is also included. And we have delineation of normal sadness from grief disorder, noticing there's going to be similarities, but we shouldn't be diagnosing somebody because they are experiencing grief. Not to say that it can't happen at the same time, but it is important to have that distinction. MDD is going to be about 2 weeks, whereas this thymia is, which is, let's see. Persistent depressive disorder, otherwise known as dysthymia, is about 2 years for adults and 1 year for children. So that's when you're going to see that the chronic experiences more prolonged time frame. Reoccurrent is more frequent than single episodes for MDD, as well in the DSM-5. included rather than it was presented in the DSM-4, but became an official diagnosis for DSM-5. Just forgot to write it down here, but that is premenstrual dysphoric disorder, which is characterized by, let's see, a depressive disorder that begins sometime following ovulation and remits within a few days of menses and has marked impact on functioning. So this is where you're going to see a system of support needed to identify supporting a client and supporting them in advocating for themselves within that as well, or even working collaterally with with providers. All right, y'all. So this is the diagnostic criteria A for major depressive disorder. We want to see 5 or more of the following symptoms, and this is gonna be for about a 2-week period. Um, a single episode is possible, but most cases are gonna be recurrent episodes. Here I have highlighted in blue, as you see, because we're going to see either one of these symptoms present. This is depressed mood. So we're going to have to see this most of the day, nearly every day, as indicated of subjective report, or loss of interest and pleasure. So this could be interest in activities for adults, interest in sexual activity, and then other symptoms that include, so if we see one of those, then we need 4 more of the last, which are significant weight loss not due to dieting, weight gain, change or more than 5% of the body weight. Now I realize that there's other factors that are going to be included with that, and we'll talk about that. Insomnia, hyperinsomnia, nearly every day. Psychomotor agitation or retardation, nearly every day. Fatigue or loss of energy, and then feeling of worthlessness or excessive inappropriate guilt. Diminish of ability to concentrate and recurrent thoughts of death. Uh, so these are the criteria, the main ones you're going to be going over with symptoms you're going to be looking for with depression. Thinking back to our characters, do they meet criteria based on for criteria A? So this slide right here is going to be criteria B through E. This is where we're going to see our notes and our exclusionaries from other types of diagnosis. So criteria B is going to be symptoms or clinically significant distress, right? They're not just minimally distressed, they're clinically significant distress. So they're maybe causing problems for social, occupational, or other important areas of functioning. The episode is not attributed to physiological effects of substance or medical condition. That's really important, and we'll talk about that. The occurrence of major depressive disorder is not better explained by another disorder, which may include schizoaffective disorder, schizophrenia, schizophreniform, and other psychotic disorders. Criteria E is there's never been a manic or hypermanic episode, which would indicate bipolar 1 or bipolar 2 um, diagnosis. Here we have some notes. This is directly from the DSM. So right here it just says A through C represent major depressive episode. Um, it's not significant loss. And in the DSM-5 TR, which we'll go over, about grief, prolonged grief disorder. So differing from that, now is it possible to have major depressive disorder and grief? Yes. Um, but that shouldn't be the main diagnosis considering someone's grief. Right here it talks about it being understandable and appropriate loss. And then thinking about expression for distress in particular cultures. Note the exclusion does not apply for manic episodes if they're like hypomanic like episodes are substance induced attributed. So if there's a presence of a um, let's see, criteria E, we have to rule out as well. Was that medication induced and not a true hypomanic or manic episode? So right here, this is going to be interesting. I know you were all in master's level courses, maybe beginning of your program. But this is what you're going to be seeing when you're diagnosing somebody in the field. So here's an example of a diagnostic code. Here's the different types of um, details to give more insight to what's going on for the client. So example here, is this a single or recurring episode for the client? Thinking back to maybe our character Eeyore. Um, I would say severe and recurring, right? Presence of psychosis. Is that a present? Is that not present? Remission status. At what point of remission are we in? And that's going to be significant to talking about different chronic levels. Um, and right, if there is remission status versus what we'll talk about more depression that lost much longer than 2 weeks, rather 2 years. Is there any remission for a client where they're able to have absence of these symptoms? And if it's not happening, then we may be looking at um, more chronic diagnosis. Example of codes. This is what this looks like. You don't need to memorize these codes. I personally have them in the chart. They're automated in our charts from when in my job positions that I've seen. So example, mild single episode, and then it has its according number. Now, some specifiers are on the side. Do you see an anxious distress specification? Do you see mixed features? Is there melancholic features, atypical features, and other examples? All right, so this is diagnostic features. Here, this pin says prioritize emotional and cognitive symptoms because this is more reliable and has less influence on external factors. So example, a medical diagnosis may have similar presentation as depression. So example, someone may present with insomnia, fatigue, body aches, things like that, right? This is still part of our diagnostic criteria, but it's important to have conversations with clients about seeing their primary care as to rule out other medical concerns. Now, to go over specifics with physical for depression, which are insomnia, fatigue, maybe the presenting complaint for some folks. In this, in the DSM, is talked about failure to inquire may result in underdiagnosis. So if you're hearing this as a major complaint, maybe someone's avoiding talking about being sad, but they're talking often about being really tired, waking up too early, waking up in the middle of the night. High proportion of folks with depression, with MDD, have fatigue or sleep disturbances. Somatic complaints such as body aches. It's important to distinguish that from actual medical concerns, as to not underdiagnose a medical concern, right? And we're not experts in that, but that's an important distinction. Something that's less common but indicative of being severe, which is psychomotor agitation and near delusional guilt. All right. Here we have a note again about this persisting for most of the day, nearly every day, for at least 2 weeks. So again, just that time frame, not just 2 weeks. Sometimes I feel, a little bit sad. This is happening most of the time, every single day. Now, with the exclusionary of weight change and suicide ideation. For children and adolescents, there may be irritable rather than sad. And this is also paired for children, is to have four other um, symptoms, which include things like changes in appetite, weight, sleep, psychomotor agitation, activity. So very similar, but the mood may be depressed, or mood may be irritable rather than depressed. All right. So here we have diagnostic features again. We're talking about specifics and some examples. So mood descriptors for A1 is going to be that criteria that we talked about in the beginning, which are uh, someone may feel depressed or discouraged. So someone may describe it as feeling hopeless, feeling down in the dumps, feeling sad, feeling bleh, having no feelings. These are some ways that you're going to hear it. Now, I'm also considering language use and cultural significance of how does someone describe their mood as being sad, right? It's relative to the self. These are just like some examples from the DSM. So if somebody is denying depression, I'm not sad, but you're noticing they're looking like um, they're looking like depression from inside out, and they just have a sad affect, and they have maybe they're near tears or they're frowning. You might ask about the physical things that you're observing. And observe their overall demeanor. Are they talking more sad, more slow than normal? Are they taking more time to pause? Do they seem difficult in concentrating, right? Getting those physical, observable demeanor um, facets in there. All right. You may also look at the physical symptoms that we talked about in the last slide, which is somatic symptoms, slower movements, things like that. Um, Increased irritability is included in here. So this may be, you know, having more outbursts, blaming others, exaggerating a sense of frustration over small things. Loss of interest in activities. This is going to be A2. So A1 and A2 is going to be either one of these need to be present for major depressive disorder. I would encourage you to, take note of these details as kind of red flags of depression. Um, to indicate more, you know, detail. Loss of interest or pleasure is nearly always present, at least to some degree. So, example, someone maybe lost loss of interest in their hobbies, not caring anymore. Maybe it's just less enjoyable. Family members may often notice this withdrawal and neglect of pleasurable avocations. So even if you're meeting with someone individual, you may say, have you gotten any feedback from your family? Well, yeah, they said that I am not as interested, but I don't really notice that because they're focused on something else, right? They're focused on the depression, not the activity anymore. Significant reduction of previous levels of sexual interest. Here I wrote a note about trauma. This is not the criteria, but what I'm thinking about is with trauma related disorders, interest may be difficult to gauge because um, someone is already trying to survive. They may not be able to have much interest from the beginning or from their traumatic experience, which can be paired as well. All right, here we have diagnostic features A4 and 6. The reason why I put these together is because I want to talk about the difference between sleep and fatigue. All right, so with appetite, we have increase or a decrease. It could be either. We also have, craving specific foods. In extreme cases, there is significant weight loss. And for children, they may not meet their weight gains that are appropriate for their age or be above their age range for development. So for A4 in sleep, again, sleep and fatigue, I want to compare these two more closely, which are for sleep. This is a key symptom for in difficulty in falling asleep or sleeping way too much. So, example for sleeping way too much, this may be sleeping a lot of hours at night, or it may be sleeping more often in the day. It either is acceptable as meeting criteria for that. What you want to see for sleeping in difficulty, what's most common is called middle insomnia or terminal insomnia, which just means waking up in the middle of the night or waking up kind of right before the alarm goes off, right before you're supposed to, and not being able to fall back asleep is that part that distinguishes insomnia. Fatigue for A6, this is common as well. Small tasks may take substantial effort. You may hear, man, that just made me so exhausted after just doing something small like doing the dishes or taking a shower. That maybe contribute to why it's so hard for some folks to meet hygiene needs because it's so exhausting. It's not just about a motivation thing. And this is relative to the self. So here we have talking about reduced. Mm, mm, mm. Oh, excuse me, I lost my train of thought. But relative to the self, which is, it may seem normal for some folks, no big deal, makes you a little tired, but maybe this feels substantially more compared to what they've been used to, right? So not comparing it to what you know about yourself or about others at that same age, but comparing it to the self. Well, is that normal for you? Oh, that's a big difference. Okay, so getting curious about that for each person. Here we have diagnostic features 5 and 7. So here we talk about psychomotor agitation and retardation. Agitation is characterized as inability to sit still, pacing, hand wringing, excuse me, pulling, rubbing of the skin or other objects. Now, this is an interesting characteristic because it could be initially mistaken as ADHD. Retardation is characterized as slow speech, thinking, body movements, increased pauses before answering. In their speech, it might be observed as decreased volume, inflection, amount of variety, context, maybe being mute entirely. So I'm kind of emulating that because I'm thinking of our character Eeyore, right? They're very flat and it's very slow in movements. So that's what you're gonna see there. So sense of worthlessness and guilt, it's unrealistic, negative self-evaluation. Maybe you hear somebody talking about themselves or getting really upset about feeling really guilty over the smallest things. So they may misinterpret trivial activities or exaggerate their sense of responsibility toward events. Example, they're blaming themselves for world poverty. These two examples here are indication of severity, right? They're going to be less common, but with the presence of this, there is very severe depression. Prevalence and suicide. So here we have some information on prevalence. So about 7% of the population for the United States experience in the last or 12 months of presence of major depressive disorder. 18 to 29-year-olds are about 3 times higher than someone who's 60 years or older. And then females experience 1.5 to 3 times higher than males beginning in early adolescence. There's no clear symptoms again for treatment response, function, consequences for females versus males. Regarding suicide, women are higher risk for suicide attempts and lower for completion, which means that men are increased risk for completion of suicide and decreased risk for attempts. Suicide risk here, this is a quote. The possibility of suicidal behavior exists at all times during MDD episodes. This is directly from the DSM, as is most of the material. But I thought this was important because they have the severity here. This is really speaking to the importance of having conversations and risk for suicide when someone's experiencing a major depressive disorder episode. The consistent risk factor here is going to be history of attempts or threats of suicide. Most complete suicides do not precede unsuccessful attempts. So that means that there doesn't have to be attempts um, preceding a suicidal completion. Increased risk include someone who is male, someone who's living alone, um, having prominent feelings of hopelessness. Increased risk for the future attempts also include borderline personality disorder. Likelihood of attempts lessens in the middle of life, though suicide completion does not. High mortality for this diagnosis, uh, it has a high mortality rate, which includes suicide. But an important distinguishment with mortality rate is that individuals who go into a nursing home often present with major depressive disorder and also have an increased likelihood of death in the first year of being in the nursing home. All right, so this is the development and course for major depressive disorder. What does the timeline look like? What is the development of major depressive disorder? Here we have the remission, which is characterized by 2 or more months, no symptoms, with 1 or 2 symptoms that are no more than mild. So when you administer a mental health assessment, you're going to take a characterization of where are symptoms landing? Are they mild? Are they severe? This is going to characterize remission. It's important to distinguish recent development versus long-term chronic depression. Um, right. So having a new client when you're talking to them and they're saying, "Hey, I'm experiencing some depression," and you might need to you follow up with some questions. How long has that been going on? Hasn't been, oh, it's been 2 years. Then we're not looking at major depressive disorder. Um, if it's been 2 weeks, somewhere between there, couple months, not related to again what physical grief, other things. So recovery, 2 out of 5 individuals experience recovery within 3 months. 4 to 5 individuals experience recovery within 1 year, right? And that's back to that minimal symptoms experience. The recency of onset increases the term of recovery, which just basically means we have a shorter experience of onset, shorter time in recovery versus longer. Recurrence for lower depression um, is congruent with remission increasing, which just makes sense over a timeline. Decreased recovery um, may be contributed with longer episodes duration, as well as psychotic features, personality disorders, and those chronic symptoms that we talked about, which are, again, psychomotor agitation and severe guilt. Differential diagnosis here, which talking about bipolar and schizophrenia, these things they may first be characterized as major depressive disorder. Then we start to talk about, oh, then we've introduced a um, manic episode. Then we're changing the diagnosis. So diagnosis is a continued conversation. And it's important to talk about that with your client because it does change what we're working on. It does change the specific symptoms that we're tracking. This specifier that we talked about earlier is one of the indicators that possible bipolar may be demonstrated later on is mixed features. Um, Schizophrenia is also more likely with somebody who has experienced psychotic features, which doesn't mean that there's an automatic development, but it's just more common to see. Um, Earlier, so for age and onset, we have onset is at any age, but there's increase in puberty, and the peak is around 20s for the United States. Onset in late life is not uncommon though. So we have really no major differences with gender and phenomenology, course, treatment, or treatment response. So some symptoms do exist though across age, which is interesting. So we're going to see more younger folks, hypersomnia, hyperphagia, versus older folks who are going to be more presenting with symptoms like psychomotor disturbances. So walking more slowly, being more agitated, things like that. Risk factors and prognosis for major depressive disorder. So, considering the environment, somebody who has experienced adverse childhood or has multiple and diverse stressful experiences. So, what's going on in their environment? What's stressing them out? Do they have history of adverse childhood? These are going to be some questions that you're going to be asking your clients. Family, someone who's experienced major depressive disorder, that's why you get asked about your family history, or where you're going to be asking family history when you do an intake to determine diagnosis, because family may have some exposure with depression. So someone who has a first degree family member with MDD is 2 to 4 times likely to also experience MDD. Someone who experiences a major non-mood disorder may also experience depression. That's where we have kind of co-occurring disorders happening. So this example is substance abuse, anxiety, borderline personality disorders, for example. The sustainability of treatment may focus on the primary needs. So addressing substance abuse, addressing anxiety, addressing bipolar disorder, or excuse me, borderline personality disorder, as a way to navigate more long-term and appropriate treatment to manage their symptoms. How does the MDD affect function for the disorder? So here we have two images. Here we have our characters back, and here's an example. Someone, Squidward's at work, and then we have Eeyore who's getting help from his friend to be protected from the rain. So you may have a variation of disorders where it's very mild, such that many of those interact with affected individuals are unaware of the depression symptoms at all. That's where you get the kind of the term high functioning, though that's not in the DSM. Complete incapacity, such that depressed individuals are unable to attend to basic self-care needs, or they're mute or catatonic, which catatonia is a severe experience. MDD is in medical settings. Um, Someone may, so of course we can experience MDD along with the medical setting. It's just important to have that distinction there. Um, so someone may experience more physical pain, and greater decrease in physical, social, and role functioning. This is the PHQ-9. We have the mental health assessment here. You may have seen this before, seen in the doctor's office. This has 9 questions. So, for example, little interest or pleasure in doing things. So the examples are not at all, several days, more than half the days, or nearly every day, right? And remember, the diagnostic criteria is nearly every day for most of the days. So you're not just going to go solely based off of this criteria here, but you're going to be including, right, little pleasure in doing things, filling that mood. These two are necessary. So it's still important to know your criteria even when you're, giving out assessments as a clinician. Go back and review that criteria. Is this person actually meeting that? At the bottom of this assessment, which is cut off, but talks about the severity. How much is this impacting your day? I use this in my work as a clinician to gain insight and to help, be able to talk about the wording. This Instead of pulling out an entire book and saying, let's go over your mental health needs, let's go over this depression. It's a single sheet, it's clear language, and it is using the same information as the criteria symptoms list, but it's important to know those ruling out and which symptoms need to be included first. All right. All right, this is another example of a depression inventory. This is Beck's depression inventory. This one has 21 questions. This example, um, and it's less of rating, but going through and kind of more detailed information. So example, I do not feel sad. I feel sad. I am sad all of the time and I can't snap out of it. I am so sad and unhappy I can't handle it, or I can't stand it. So here's that distinction there. What's coming to mind is this language of snap out of it. Someone may not be familiar with that. So this right itself is an example of cultural significance and being able to work with your client. I think that this one has a little bit more detailed information, and talks about the maybe beliefs that this person has. Feeling like a failure, particularly discouraged about the future, getting as much satisfaction out of things as I used to, right? That's the um, interest of things. That's one of the major criteria. So here we have topic of culture and gender. Gender we went over a little bit earlier, which is about there's really no difference with onset and treatment or expression for gender. There is a difference with suicide. Here we have majority of countries, depression goes unrecognized in primary care. And this is going to be possibly because somatic symptoms are likely to be the presenting complaint, as well as insomnia. So the physical symptoms are being reported, um, and we need to inquire more. That's an important distinguishment from the DSM about culture, and across multiple countries. Here I have a list of identities to consider when thinking about different or intersections of culture, and identities. So this is just part of the list. This is not everything. But considering how depression may be showing up or supported even with these different identities, and including the different stress factors that may be involved. How might a person express their mood? How might, remembering that this is relative to their self, right? They may feel more fatigued, and it's important to distinguish that against their self and being curious about the intersectional identities. Here we have another section here about culture and some articles I found. I'll include them at the end if you want to look at them. Um, Here we have less prevalence of depression in collectivist cultures, which I thought was interesting. So collectivist cultures is one of those intersectional identities on the last slide. Um, there's a lack of data for low-income countries, so there may be interesting findings that needed to support these areas. Um, yeah, and then this study right here for immigrants in the United States. Oh, I did not capitalize that correctly, which is the fastest growing migration. So for Black individuals of sub-Saharan Africa, um, and the mental health needs for this group because it's a fast growing population. And what's found, this was a qualitative and quantitative study, and there were some interesting quotes in there from the individuals, which I think is a great strength of that qualitative study. And they talked about kind of being in between the cultures, not quite being able to relate to Black individuals who are American, and then the immigrant population. Someone talked about being mainly geared toward Latino community. So feeling really in between, and how does that impact this desert or missing people within mental health? So some findings to support are include implementing culturally valid therapy, faith-based therapy. This quote here, architecture invisibility, which refers to that structural kind of missing somebody because there's a cultural need that's not being addressed and not talked about enough for our clients. So here's a list of differential diagnoses that are listed in the DSM. Some of these we talked about already, and you're going to be familiar with them at this point. Manic episodes with irritable mood or mixed moods, mood disorders due to other medical conditions, substance and medication, ADHD, adjustment disorder with depressed mood, and general sadness, right? So it's important to notice kind of what is it that we are needing to address and how does that affect the client. This helps us understand like where we're going to go and what kind of symptoms are we actually looking for. How do we know we're helping our client, right? With someone who has major depressive disorder versus ADHD, we're going to be looking for different things, right? So that's important to keep in mind as you develop as a counselor, is that diagnosing is important not just for insurance, right? The insurance companies, yeah, I hear, annoying things and stuff like that. Um, but it really does help us as clinicians to distinguish what type of diagnosis is going to help this client the most. All right, so I included this slide, unspecified depressive disorder, because I thought it was important to talk about with major depressive disorder. We're thinking, okay, I have to meet all this criteria, and I have to make sure that it's not these other things. Fear not, we have unspecified depressive disorder here. This is where we're not meeting enough criteria. Maybe you're meeting the client for the first time, and you just don't have enough information. You have more questions to ask. Maybe they meet other criteria, but they don't have the first two, or at least they haven't talked about the first two um, criteria A symptoms, which again are mood and loss of interest, right? So we have this diagnosis here, which is on page 184, um, and it should not be a long term thing. It should be kind of a placeholder and then being able to get more information. So cognitive behavioral therapy is going to be an evidence-based practice for depression disorder. And I think this one is a great one. I don't know where the resistance comes with it. I encourage you to challenge that in yourself as well, like the different types of evidence-based practices. Um, Challenge, where does that come from? This resistance with CBT, though it's a gold standard in the field. So CBT is thinking about or utilizes how thoughts, feelings, behaviors, and also beliefs intertwine, and the improvement of one is often an improvement in the others as well because they're connected. CBT aims to modify unhelpful thinking and behavior patterns that impair functioning. Now, this is directly correlated with what we've been talking about the whole time. Major depressive disorder. What did we talk about? The beliefs, right? Thinking about the guilt, thinking about how the behavior is unhelpful. Maybe someone's incredibly tired and they're unable to get in the shower because it wipes them of all of their energy. These are unhelpful, and this is impairing functioning. Maybe it's impairing their ability to go see friends and things like to hang out and have fun. That is impairing someone's functioning and quality of life. This is typically delivered 6 to about 20 weekly sessions. With cognitive behavioral therapy, we're talking about differentiating between thoughts, feelings, and then questioning that assumption. So for our characters, I encourage you to think about what kind of questions would you, as a clinician, ask them to um, question their assumptions about the world? How would you ask them to question their thoughts and feelings and be able to differentiate between maybe thinking maybe more negative experience? We want to identify and label types of thinking patterns. We're going to address behavioral patterns as well, which are identifying lack of enjoyment, and identifying activities that they once enjoyed and planning to do those things. So there's an actual piece with CBT as well, with the behavioral side, of course. So for cognitive behavioral therapy, we may educate the client about CBT. So we talked about how the thoughts, behaviors, feelings intertwine and how improving one is going to improve another. So we're going to talk about the actual education of how does the treatment actually work? And that can be helpful for a lot of clients to understand what's going on. It can be transparent to what is actually happening in their therapy. Techniques may include a mood diary outside a session. What influenced their feelings and behaviors? Are they connected in it, or were they connected in the moment? And how did that impact the client? Here we have an example of an emotions log, which is pulled from Therapist 8. I just pulled a little snippet of it, which has the emotion. So the anxiety, the trigger, what was the behavior, what was the consequences. And you could do this, as an example from any journal, or printing this out and giving this to the client may be helpful, or just writing it on a general piece of paper. Then we're going to be looking at cognitive restructuring. So for example, with this example pulled up on the screen, anxiety, big exam coming up, procrastination over the weekend. Anxiety went down briefly, but then got much worse on Monday. So cognitive restructure might be, I'm scared for this exam and I'm capable of studying for 10 minutes. And then behavioral follow through of studying for those 10 minutes, which overall may decrease that anxiety. Now that's the example for anxiety. Um, what would be an example for depression? I encourage you to write this down, and fill out maybe a trigger log that you make that the characters may experience. All right, also I included this slide here with the medication to talk about one example, which is an SSRI or second generation antidepressant. The SSRI stands for serotonin reuptake inhibitors. This is a very, very brief example. It talks about um, brain function and release to mood and behavior. Um, Likely with intakes, you may experience asking clients, what kind of medications are you taking? And we're not experts in the field of medication. I think it's important as clinicians to get familiar with what kind of medications are out there, and what do they treat.